So the one thing that I think OCT has been able to do is really allow us to look at the retina three-dimensionally, to be able to see and recognize when patients have retinal thickening. Before the OCT, it was really relying on your three-dimensional abilities with a 90 or a 78 or even a contact lens and recognizing if there's retinal thickening and if that retinal thickening was clinically significant. So there's no question when OCT came along, it really provided that level of sensitivity to really see architecturally changes within the macula, whether the retina was thickened, whether you could see cystic spaces within the retina. And I think the one thing that we really were not able to see is retinal ischemia. So on clinical exam, we could see retinal hemorrhaging, we could see cotton wool spots. Again, we were able to diagnose with a greater sensitivity if there was diabetic macular edema. But what we weren't able to really see is when there was ischemia. So I think that's really one of the big game changers in one way I use OCT angiography. So again, still being able to look architecturally at the macula, is there any diabetic macular edema, is there thickening? But again, that next level is there any areas where there's capillary dropout or low flow? Here's an example of a patient who still has visual acuity of 20/20, and we would probably see mild to moderate non-proliferative diabetic retinopathy. But you can see on a microvascular level some of the architectural changes within the capillaries. You're seeing that capillary dropout or low flow that's just temporal to the macula. Here's another example of that, a patient who again is 20/20, and you can start to see that widening of the capillary free zone. And a patient that on a clinical exam, you just wouldn't be able to see or recognize that. And so again, from an optometric perspective where I don't have access to traditional fluorescein angiography, to be able to capture that image in a matter of a few seconds and really see with very high resolution what's happening on a capillary level, to me is really remarkable. Alexandra, what has been your experience in particularly patients with diabetic retinopathy being able to see and capture low flow or ischemia?
I agree with you, Mark. I think it's been tremendous for that because I still use a lot of fluorescein angiography, obviously, because with the current technology in OCT-A, we can't quite go out as far as wide field fluorescein angiography is capable of doing. But when it comes to analysis of the macular ischemia, enlarged FAZ, and dropout of the capillaries, I think that OCT angiography is superior when it comes to diabetic patients, because you can really see the areas of ischemia and you can show it to the patient and educate the patient as well. I would warn people when they analyze patients with diabetic eye disease and they look at OCT-A, if the patient has diabetic macular edema as well, that might appear different, and you have to be able to differentiate the two, DME and ischemia. But I totally agree with you. It's a super helpful tool for that.
And plus, with traditional angiography, you just didn't have quite the resolution. I mean, you could see ischemia, but with the fact that it's digital and we're looking at really a higher resolution, we can see this is a 6x6 scan. It'd be nice to have a 3x3, but you'd even be able to still capture the fine detail of the capillary dropout. So to me, it's really been a game changer in looking at these patients who have diabetic retinopathy. So let's look at another case. This is a patient who's 33-year-old Hispanic female. She's a type 1 diabetic since the age of 8. And unfortunately, like many patients that we still see today, she has not had well control of her diabetes. Her A1C on this visit is over 11. You can see that she's had laser treatment at least 2 years prior to that, and she's really had pretty full PRP, what I would say. And so I still see these patients, again, in a primary care setting. This is somebody who's, in a sense, fallen off the radar, if you will. Their insurance changes. They don't know where to go to, and they finally connect with an eye care provider. And so you can see, I think, beautiful fundus photos of both eyes showing full panretinal photocoagulation in both eyes. And interestingly, a lot of times these patients tend to be pretty stable. I have a lot of these patients that I will see really twice a year. They've had laser 15, 20 years ago, and they're going along pretty well. The proliferative disease has essentially regressed. They've maintained good visual acuity. However, this is a patient where that's really not the case. And I'll let you look at the right eye in more detail. You see along the inferior arcade, maybe a little bit of flame hemorrhage, but take a look along the superior arcade, and you can see this very large neovascular frond. We'll show in just a second, she does not have any diabetic macular edema. And again, just the mere presence of the fact that she's got neovascularization indicates this is a patient who needs to be connected or needs to see a retinal specialist. But again, I want to highlight just how nice OCT angiography is in an example like this. And so you look at the B scan below and you can see that there isn't any retinal thickening, so she doesn't have any diabetic macular edema. You look on the OCT angiography and you can see, you know, some changes in a capillary level. You can see some pruning of the vessels to some degree. But where it really is remarkable is when you do the OCT scan along the arcade. And you see very nicely, very beautifully, this neovascular frond. And to remember, with traditional fluorescein, this would begin to leak. And you would see, and again, that's just classic of neovascularization when you're doing traditional fluorescein. With OCT angiography, you're not getting the leaking. So you're really maintaining the patency or architecture of the vessel, if you will. So this was one of the earlier cases when I started doing OCT angiography. And again, it doesn't change how I'm going to manage the patient, but just to be able to visualize what's happening, you know, on a microvascular level. And the next slide, to me, is really what I think is a beautiful picture, where you're also able to see the ischemia. So adjacent to the neovascularization, this is a patient where you're able to see large areas of ischemia or capillary dropout. And so again, to be able to capture that without having to do an injection, again, in an optometric setting was really, I think, a great advantage for me to have. The left eye, not quite as bad, although she does have neovascularization superiorly. I think you can see that. She's got neovascularization along the arcades as well. And again, on the OCT angiography, though she doesn't have any diabetic macular edema, I think you can see that she's got some low flow areas and she's got some very obvious ischemia. And so, as I said, this is a patient that I ended up referring to a retinal specialist, hoping to get her seen within the next couple weeks. Unfortunately, like many of our patients with, you know, I shouldn't say many of our patients with proliferative diabetic retinopathy, because that's probably not a true statement, but like many patients that we sometimes see, they just fall off the grid, they don't follow up. And this is here, her patient, my patient, 2 years later. She didn't come in, and it was like 9 months after that. And by now you can see she still doesn't have macular edema in the right eye, but the left eye, now you're starting to see cystoid macular edema, and really, in a sense, a very sad case, because I think we probably could have done more earlier and really prevented her from getting to that stage. Do you have any comments, Alexandra?
Mark, I think it's a beautiful case, and I think ability to capture some of the peripheral changes that we see in diabetic retinopathy is very key. There, at our big national meetings, there's several presentations where we look at either wider field OCT-A or montage OCT-A, and we're able to capture IRMA, we're able to capture NVE and NVD. And the question is, will it change the way we approach these patients? You already alluded to sometimes you might not have access to fluorescein angiography. You know, you might be in a practice that doesn't have it, or you might be in a satellite that doesn't have it. And be able to establish the level of the disease and the need for treatment, OCT-A can be very helpful. I think also these patients a lot of times have other comorbidities. It's hard to get access. You know, they might have kidney disease, all those things that we think about when we schedule somebody to get fluorescein angiography. And fluorescein angiography, you know, we do look at that leakage, but I think as we're studying more and more the biomarkers, how they appear on OCT-A, that might change the way we manage these patients. It's such a non-invasive way. It's easy to do. It's easy to get good quality pictures, you know, that in terms of time in the scanner for the patients to maintain vision. So I think that that is very helpful, and I'm excited to see what the future brings with wide field OCT-A for this patient demographic.
There we go. So here's another, I think, very typical case of a patient who has non-proliferative diabetic retinopathy. The right eye, I would gauge at about moderate. The left one, there was a debate whether it's moderate and severe, moderate versus severe. So again, I think the advantage of wide field imaging, being able to really, and this isn't a real wide field image, don't want to kind of claim that, but I think it's wide enough that you're able to see beyond the arcades and see, particularly in the left eye, is there hemorrhages and microaneurysms in at least 4 quadrants. It's difficult to see if there's any venous beating. I believe there is. And then again, in this image, it's hard to see if there's any IRMA, but they're really almost on that threshold where if you're not sure, this is a patient that probably should be seen by a retinal specialist. There's some new data that has come out, showing that if we can treat these patients earlier before they reach the level of proliferative disease, we may be able to turn the clock back on these patients before they ever develop proliferative disease. And so this is, again, a very typical type 2 diabetic for the last 7 years. They don't know what their hemoglobin A1C is. Their visual acuity is very good in each eye. We ended up doing a note, and this is the wide field image. Alexander, what do you think about this left eye? Would you categorize this as being moderate, or do you think it's reached the level of severe? Just out of curiosity.
I think, I think it's interesting because if you look carefully, even on the right eye, there might be a little IRMA hiding along the superior arcade. So I would be concerned for this patient, and sometimes I will tell you the exam and even images, color fundus photography could be underestimating the disease. And a lot of times when we get additional images, we can actually find significant areas of non-perfusion and some of the IRMA and maybe even NVE changes.
And here's a close-up view of that probably highlights that very well. I think you can see inferior, maybe some venous beating. Again, I don't know if there's any IRMA there, but I think it's close enough that this is a patient that, again, in light of some of the newer data coming out on treating diabetic retinopathy early, this is a patient that might benefit. So yeah, I ended up sending this patient to be seen by the retinal specialist. Actually, I hadn't seen the patient yet. I would have. This is the OCT, of course. And again, there's no diabetic macular edema. What I wanted to highlight is the fact that, of course, as many of these patients, if they're not followed closely, there is a risk of progression, and that's what we're seeing in this patient 3 years later. They have also a combination of poorly controlled high blood pressure, and this patient gets hospitalized for the hypertension. And so that combination really sets a stage for worsening in the level of their diabetic retinopathy. So at this point in time, there's no question, I think this patient has severe NPDR, and we're going to look in the scans here in just a second that they may have diabetic macular edema as well. And so again, this is a montage image just showing more extensive hemorrhages and microaneurysms in all 4 quadrants in both eyes. And when you look at the OCT angiography, again, as I alluded to in the beginning, this to me is really for an optometric practice to be able to look at the microvasculature of these patients and see ischemia, starting to see widening of the capillary free zone, and just really pruning of the vessels is really remarkable. And again, this patient, when you look at the B scan, they don't have any diabetic macular edema, but yet you're starting to see some ischemic changes within the macula and even a little bit further out. In the left eye, again, really, even though you see exudate, it really doesn't look thickened, so that's surprising. But again, you can see some of the ischemic changes both on the 3x3 and the 6x6 scan. So again, from my perspective, not really having the ability in my practice to scan and see, the level of detail that we're now able to see with OCT angiography really is quite remarkable. So again, this is a patient that I think needs to be seen by a retinal specialist, possibly for treatment. How would you handle a patient like this, Alexander? Is this somebody that gets early treatment?
I think I'm very concerned about this patient, and especially given the progression that you've shown in this case. And I think all the patients that you referred, obviously, is very appropriate to be evaluated by a retina specialist. I would be concerned that there might be some actually early proliferative changes in this patient. So I would consider getting maybe an FA on this patient and then instituting possibly treatment. And especially, you know, if it's a patient who has already established a poor compliance pattern, we
Yeah.
always worry about those patients because diabetes is a chronic disease. It's the disease they're going to have for life. And the damage that we see, it accumulates over time, and it only gets worse unless they're controlled systemically and stabilized from the eye standpoint.
And you alluded to the need for wide field angiography, and we're getting there, I think, with OCT angiography, and we're able to do the montage. But that's really, at least in this case, the limitation, right? Where you're not able to see, are there any areas of neovascularization further out that we're just not able to see or pick up? And I think this would be a great example to be able to show that if we had it. But again, from a primary care optometric perspective, this is a patient that I think needs to be sent out, obviously, to the right place and ultimately, you know, maybe treated.
Great. So this is a case that I titled When OCT Looks Dry. And this is a 76-year-old male. He has a diagnosis of central retinal vein occlusion in the left eye. His right eye is normal. The visual acuity in the right eye is 20/25, and visual acuity in the left eye is 21/25. This patient initially presented with significant macular edema with both intraretinal and subretinal fluid, and has undergone several injections of anti-VEGF agents. And his vision kind of stayed the same. And this is what the images look like. We can see here a wide field image of the right and the left eye. And on the right eye, he has a horseshoe tear that has been treated with laser, but otherwise looks normal. On the left eye, we have a view of peripheral PRP and some ischemic vessels. And this is OCT image of that left eye. And you can see if you just briefly look at it, and you know, when we talk to patients, we show them the images from before and after, and he had an Everest of fluid, and now he looks so good anatomically. We really don't have any fluid. There's definitely thinning of the retina and the abnormality in the layers of the retina. But for a patient, you know, he's like, I don't understand why I'm looking so dry, but my vision is no good. And so I think when it comes to taking care of patients, it's not only us telling them what they need to do, but explaining to patients so they can have an insight into their disease. And I think that really helps them to control their disease. This patient obviously has systemic risk factors. For him, it was hypertension, and we talked about the control of that. So we obtained additional imaging to evaluate this, and here's his FA image, wide field, and we can see the areas of peripheral non-perfusion and the reason why he had PRP, panretinal photocoagulation. We can see the laser, and we can see that in the temporal macula, he has significant area of non-perfusion that's obvious on this fluorescein angiography. It's harder to say, though, what things look like in the in regards to foveal avascular zone, and I'm going to show you a couple of the images of OCT-A, and I think this shows very clearly to the patient the difference. And I always like to pull the normal and the abnormal or the diseased eye. You can actually see, I want to point out that there's a couple artifacts on the left eye, because you can see how the vessels kind of interrupt, and that's because of the motion artifact, because the patient has harder time fixating, but we still obtain very good image where we can see that there is significant non-perfusion. And think back to that fluorescein angiography. It really looks much more pronounced, and you can get an idea what's happening more at the macula and foveal level. And compared to the normal right eye, there is all this ischemia, not only in the temporal macula, but also centrally. And let's see if I can advance to the next. And you can see as we zoom in this image, how large his foveal avascular zone is. and how irregular vessels are. And once again, you can see that kind of jumping interruption in the vessels. I don't know if you can see my mouse, but that shows that there is some artifact from him moving because he has hard time fixating. But even with that, I think we get very useful information, and we can educate our patients and then talk about the plan of care as we go forward. So this is, I thought it was great because this patient, after I showed all of this, he sent me a message through electronic medical system. And he said, I was really impressed by the blood vessel imaging. And in fact, he wanted to be directed to a website where he could learn more about the device. And I thought it was tremendous. And he said, it's in a pursuit of intellectual interest. I want to learn more about it. I think this technology is awesome. And the other part of the quote I thought was great is he says, you know, thanks for taking care of me, but the results are dramatically clear. And I think it's so important because once you know you get the patient to be on the same page and they understand what's going on, they're more willing to receive the appropriate treatment and partake in their own care. So I thought it was tremendous that that's the response he had, and just showing how much we can educate our patients. And to Mark's point about previous cases, we have a lot of patients with diabetes who might be actually asymptomatic, right? Unless you have diabetic macular edema, you might not realize that you have all these peripheral changes because your vision is still 20/20. And those peripheral changes could be very significant, and untreated can lead to complications such as vitreous hemorrhage and fractional retinal detachments that could be vision threatening long-term. And obtaining images where we can show those abnormal blood vessels, where we can show non-perfusion and showing the normal. A lot of times I just go to a website search engine and put in normal OCT-A or normal FA and show, okay, this is normal and this is your eye. And you don't have to go to medical school to tell me these two pictures don't look the same. And that's why we need to do, laser, or we need to do injection, or we need to make sure we talk to your primary care doctor and endocrinologist and get the team going so we can take care of you. I think the patients are much more educated, and all this technology allows us not only take better care of our patients, but also allow patients to take better care of themselves. I don't know, Mark, if you've had anything similar experience, or if you want to comment.
Yeah, I mean, to your point, it really personalizes the care that they're getting. That, you know, they're not just a patient with diabetes, but when they see their own retina, and you can, again, in the era of technology, where with a wide screen you can show them, this is your retina, these are the changes that we're seeing, and you compare that to normal, it really becomes very personal. And that may be what it takes to get somebody to do a better job of controlling blood sugar, or making sure that they are coming in more regularly because they see, you know, the cost of the disease on themselves. So I agree 100%. I think it's been incredible.